So he will, I will ask him to present his interns if he's available to do so. I also know he's got some other commitments during this time. Anyways, I want to welcome everyone to our Thursday research conference. And as always happens at the end of the summer, we will have presentations from our summer interns and talk about the work that they did over the summer. We have 90 minutes for 3 interns, so they'll talk perhaps up to however long they've prepared, maybe 20 minutes or so, and then there'll be some time for question and answer. Just before we start, most of you probably saw the unfortunate news that the university is going back to restricted operations due to the COVID Delta spike. We will be continuing these virtual sorts of activities for the foreseeable future, probably for the rest of the calendar year. And hopefully things will turn around quickly. Okay, well, I think at this point, maybe I will turn over the floor to Dr. Dorr, and he can introduce Ellie Chang.
Great, thanks. We've been pleased to have Ellie. I've asked my interns to introduce themselves. So Ellie, why don't you just take it away?
All right, sounds good. Okay, is this working? Okay. Hi, everyone. My name is Ellie, and I'm currently an intern here at OHSU over the summer. I'm a rising junior at Princeton studying computer science, and today I'll be talking to you all about the project I've been working on this summer with the high blood pressure team. I would like to start by thanking everyone who not only made this internship experience possible, but also incredibly enjoyable and fun. I would specifically like to acknowledge the high blood pressure team, including my mentor, Dr. Dorr, along with the rest of the Care Management Plus team, and also the Department of Medical Informatics and Clinical Epidemiology. First, I'll introduce the high blood pressure project and then talk about the specific projects I've been working on this summer. Nearly half of adults in the United States have high blood pressure, also called hypertension. According to the CDC, only 1 in 4 adults with hypertension have controlled blood pressure. Uncontrolled blood pressure increases the risk of heart disease and stroke, which are 2 of the leading causes of death for older adults. Although clinical guidelines for the treatment of hypertension represent a wide breadth of biomedical knowledge, the implementation of these guidelines is still inconsistent and resource intensive. Guidelines often conflict on the appropriate diagnosis and treatment of hypertension. Even definitions for what blood pressure measurements constitute stage 1 and stage 2 hypertension are varied. These inconsistencies require leveraging provider experience, gathering and assessing knowledge and data manually, and attempting to integrate many distinct factors and options, often resulting in inadequate hypertension management for patients. Additionally, similarly to many common conditions, there is a plethora of decisions made from diagnosis to treatment. Decisions that, despite involving healthcare providers, are largely dependent on the individual patient. For example, a patient's other pre-existing health conditions, side effects, and demographic factors can significantly influence the approach needed for effective treatment. In addition, behavioral and lifestyle factors such as alcohol consumption and physical activity can also substantially affect treatment and outcome. The ability to create computable and personalized guideline-based recommendations would not only shorten timelines and reduce required resources, but would also improve overall care. As such, the high blood pressure team has been developing a patient-facing clinical decision support, or CDS, tool that translates hypertension guidelines into practice using clinical query language, or CQL modules. These modules incorporate personalized patient preferences through direct usage by patients. This approach elicits the information needed for patient-facing clinical decision support, as well as appropriately allows patients to self-assess treatment progress and adherence through a workflow-sensitive solution. Specific innovations in this project include the use of blood pressure sets to match guidelines, a counseling goal and preference system for non-pharmacologic recommendations, and specific patient and care team versions of the recommendations. As an integral part of this project, we created recommendations that patients will be given based on their engagement with the tool. In total, we use 8 clinical guidelines that encompass 71 recommendations as the foundation for the logic behind 6 different workflows. The diagram here shows a brief overview of how the app works. When a provider orders home blood pressure monitoring, the patient is introduced to the app, which will give them different recommendations that allow them to take action. The data that is pulled in and used to drive the recommendations comes from electronic health records, as well as engagement with the app itself. Clinical Quality Framework, or CQF, ruler uses CQL to encode the logic to generate cards, which are the recommendations that patients and care teams are shown. Over this past summer, we have been working mostly on developing the initial diagnosis and monitoring workflow, as well as the non-pharmacologic interventions workflow, which will be shown on the next slide. The initial diagnosis and monitoring workflow, as shown here, makes an initial evaluation based on a patient's set of blood pressure readings, and then shows the patient a recommendation associated with this evaluation. For patients with high blood pressure who have not been diagnosed with hypertension, the tool considers a possible diagnosis for the patient, and the patient is recommended to reach out to their care team to confirm the diagnosis. As mentioned earlier, the workflows use blood pressure sets, which is defined as at least 4 office or 6 home blood pressure measurements. If the patient does not have a full set of measurements, they are recommended to take measurements first. Using a set of blood pressure readings to make a tentative diagnosis is crucial because, according to one study done in 2020, not having enough measurements leads to a much higher risk of overdiagnosis. Having a fixed definition of a set would reduce this risk. Additionally, patients who are monitoring their blood pressure at home may get a high blood pressure reading and become worried about the reading because they might not fully understand what the value means. Having this app at home may help alleviate concerns because it can tell them exactly what the reading means and what their immediate next steps should be, or perhaps it may let them know that the worry is unfounded. For patients already diagnosed with hypertension who also have an unmet blood pressure goal, the tool might suggest non-pharmacologic interventions through this workflow if such interventions are deemed applicable for the patient. For some patients, pharmacologic solutions are the best first step to controlling their blood pressure, but often non-pharmacologic therapies are key. The non-pharmacologic workflow on the left involves the output of 5 different sub-workflows: tobacco cessation, weight loss, alcohol moderation, physical activity, and nutrition. Given specific information about the individual patient, the patient is shown sub-workflows relevant to their own behavior. For example, if the patient is recorded to be a current smoker, the tool would go to the tobacco cessation sub-workflow as shown on the right. Since the engagement aspect of the tool is really important, the app asks the patient to set different behavior goals relating to these non-pharmacologic interventions and then proceeds to keep track of their progress. There's a lot of evidence that showed the effectiveness of non-pharmacologic interventions in controlling blood pressure, but these interventions often don't get implemented effectively in a clinical setting. The app this team is developing is unique because it encourages patients to implement these non-pharmacologic therapies independently or alongside their care teams through self-management support. Along with the app, the project involves creating an implementation guide so that clinics who might use the tool in the future can best understand why certain decisions were made in the creation process to balance clinical reasoning with the pragmatic approach to programming the app. Ultimately, the implementation guide will allow for people to implement the tool most effectively. This summer, I worked on writing up functional descriptions of the workflows I showed in the previous slides for this implementation guide, translating the workflows into a readable paragraph format. An example description is shown on the right side of the slide. The functional descriptions are equivalent to a line-by-line set of comments for code that allow the reader to understand the purpose of each line. The reader of the implementation guide would be able to read the description and understand the logic of the workflow and understand how exactly it fits into the tool. Working on these descriptions really helped me familiarize myself with the logic of the workflows and helped me a lot when working on the actual recommendations the patients would be given. All the recommendations are compiled into this Excel file. Each row shows a distinct recommendation or CDS card with the patient and care team versions of the text, along with other informational columns about the recommendation that are not shown in this slide. The work I did focused specifically on the recommendations that are shown to the patients. The way that these recommendations are presented to patients is critical because it determines how they understand and respond to it. I revised the text to be more concise and easier to understand for people who may have little to no knowledge about hypertension. I also found links to additional resources that would be helpful for patients to use, whether that was providing supplemental information to help the patient understand more about their condition, or information about how to get started on certain non-pharmacologic therapies, such as low-sodium diets. The recommendations encourage patients to work alongside their care team in the treatment process in the hopes of empowering the patients to manage their own care. Shown in this slide is an example of a page of recommendations that a patient might see. This HTML was generated by the app from a JSON response file of a test patient using the tool. There are 3 recommendations shown here, but each one has a similar structure. The colored circle on the left shows the indicator status of the recommendation, green for informational and orange for warning. The recommendation summary is the bolded text at the top of each recommendation, and the patient text that I revised is shown below that. Each recommendation also has suggestion types associated with it that are recorded in the recommendations row in the Excel file I showed earlier. In the first recommendation shown, the patient has a blood pressure goal that they have not reached. So the type associated with the recommendation is a suggestion link shown on the right side of the page with a link to contact the patient's care team to continue treatment. In the second recommendation shown, we see that the patient is also a smoker who has not received counseling for smoking cessation. So they are shown a recommendation with a counseling link type. This counseling link is shown below the patient text as a link to relevant resources. This patient has not set a smoking cessation goal, so the recommendation also has a goal type. As such, on the right side of this recommendation, they are given different options to set a goal to reduce smoking. Essentially, the structure of each recommendation is determined by its suggestion types. In the actual app, the information taken from the CDS cards Excel file shown in a previous slide is translated to CQL modules and then a response JSON file. All this information then becomes the actual HTML display or the user interface that the patients see based on the information fed to the tool. However, we didn't have an efficient way to quickly visualize and test the individual recommendations the patients would see. During my internship, I worked on a small project to fulfill this need. The product is a Java program that uses the CDS cards Excel file as input, taking information from a single target recommendations Excel row and produces an HTML file corresponding to the target recommendation. Essentially, it takes an Excel file shown on the left and converts it to the HTML file as shown on the right. An example output is shown in this slide. The input for this program was the recommendation number 23C, which involves diet counseling and goal setting. The Excel row for this recommendation is shown at the top of the slide, and the HTML display for the recommendation, which is what the program outputs, is shown at the bottom. The green circle at the left of the display indicates that the recommendation indicator is informational. The bolded text is the recommendation summary, and below that is the patient text. As you can see, this particular recommendation has a counseling link type, which is shown as the link below the recommendation for diet counseling, and on the right is the recommendation's goal type. The patient is given both a free text option and a fixed set of choices to select from for their diet goal, which gives the patient a bit of flexibility. The patient is also asked to pick a date by which to reach their goal and then commit to that goal. The structure of each recommendation's HTML that this particular program generates emulates the structure of the recommendations generated by the actual app shown in the previous slide. This program will essentially allow us to test and visualize each new recommendation as soon as it is created in the Excel file. This would bypass any bugs or troubleshooting that may arise in the actual app's much more complex procedure. Finally, during my internship, I drafted up a poster for the 2022 American Medical Informatics Association Summit, and if the submission is accepted, I will be able to go to the conference and present there, which would be incredibly exciting. Picking a few takeaways from my internship, I would say that my experience here has given me so much more knowledge about hypertension and the difficulties that providers and patients alike face during the treatment process. Additionally, working on this project has made me better understand the importance of patient engagement and how giving a patient more agency is a prerequisite to the successful care of a condition like hypertension. Lastly, I was able to pick up the basics of CQL and HTML while working on the mini Excel to HTML project. I think this internship has been really helpful for me in terms of figuring out my future career path as well. I'm really grateful to have had this opportunity this summer to work with the CMP team on the high blood pressure project. So I would like to thank everyone again so much for making this experience possible.
Great, thank you. Very interesting talk. Are there any questions from the audience? If not, I will ask one. It's great to see that the kind of emerging standards for moving information around between applications on the internet is finally coming to fruition. Even just a few years ago, these standards were not developed enough to be able to do this. Did you encounter any limitations of any of the standards like FHIR or CDS cards that anything that you maybe wanted to do but were not able to do because the standards were not ready or mature enough?
Not on the specific projects that I was working on. I think it was pretty easy to work on because like there are not really any limitations to creating like recommendations in the Excel file. And so what I worked on was just like translating that into the actual HTML. But I think a good limitation that Dr. Doran I discussed earlier is just that because so much of this is moving online into things like applications where patients can interact with them, there is a lot of like potentially a digital divide. Perhaps people would find a tool like this not easy to use or not be able to understand how to use it, or maybe don't even have the technological resources to access it. So I think that is definitely one thing to consider when moving forward.
Great. Any other questions or comments? Okay, well, thank you very much. I too am hoping to get to the AMIA Summit meeting next spring. We'll see. Hopefully, COVID will be behind us, and it will be great if you have an opportunity to present. So let's move ahead to our next presenter, who actually spent the summer working with me as an intern in one of my research projects. So our second speaker is Karen Garcia, who is a sophomore at Portland State University. She's local, lives in Salem, Oregon. Is also part of a program that some of you are familiar with at Portland State called Build Exito, that our department and Dr. Cindy Morris have connection to, that aim to help people move towards careers in clinical research. Karen is going to go ahead and present.
Oh, sorry. I didn't realize I was muted. Can everyone see my slides okay?
Yeah, we can see them fine.
Okay. So, as Dr. Hirsch already mentioned, my name's Karen, and it's great to see you all today. And I was very lucky to be given the chance to delve a bit deeper into the world of machine learning through the means of this project. And an overview for this presentation is going to be about the purpose behind the TREC COVID project, a brief overview on information retrieval and evaluation techniques, the TREC COVID task goals, questions examined through the TREC COVID task. So, what specific things are we looking to solve? The TREC COVID task steps, the results, any difficulties that is encountered in this study, and further plans and possible proposals for the future. And finally, the personal takeaways and acknowledgements. So the purpose of this whole project was that, we're currently in the digital age and news is spreading faster than ever. You know, there are just hundreds and hundreds of articles from various different sources being churned out every single day. And within the COVID-19 pandemic, it was evident how easy it is for news to be changed, how easy it is for news to be spread, whether it's valid or not valid. And it's also evident how life-threatening this can be. As you can see, Facebook is a common perpetrator. And then, but even then, just with cases going up, it's very hard to kind of have that peace of mind when it comes to looking for information online about our current pandemic. So information retrieval is the acquisition, organization, and searching of knowledge-based information. And this is the basis of the TREC COVID task. Information retrieval is used everywhere. It's the basis of this experiment. And basically, so the way it works, say when you go on Google, you type in a few keywords, you type in a question. So that would be your search query. And then the information retrieval algorithm sifts through hundreds or millions of documents and ranks them from which one is most important, and then returns to the user the most relevant ones. I guess in simple terms. So, and everybody engages with information retrieval processes each day. It's on Google, it's on YouTube, it's everywhere. And, back at its first beginning stages, it was focused on text and articles, but then it grew to accommodate for videos and various kinds of media, such as chemical structures and DNA sequences, which is how it's applied to the medical industry. So there are two types of retrieval. The first one is exact match. It returns all documents that match exactly with what the user entered using Boolean operators. Partial match doesn't require Boolean operators, and it's a little bit more different. And then the information retrieval process works like this. So the user poses a query, and then the search engine matches the query to the metadata. And the metadata of an article or of a link, it contains typically the author of an article, the date it was published, and the file size. And this metadata is used to search through the files a lot more efficiently and a lot more quickly, rather than having to use other inefficient methods. So an important way to evaluate if a search engine is efficient is how, first of all, if the system is used. Second, what is it used for specifically? And third, how well did someone use the system? And if it's very user-friendly, and if it's accessible. And 4, are the users satisfied? Did they find what they were looking for? Did they have an easy time finding it? And 5, what factors are associated with successful or unsuccessful use of the system? So, is it clear within the algorithm if successful use, how are you going to measure that? And it's important to have an idea of how you're going to measure success and unsuccess with one of these algorithms. And 6, did the system have an impact? Did it make anything any easier within a research process? And then a really common type of system-oriented evaluation is recall. It's the number of retrieved and relevant documents over the number of, divided by the number of relevant documents in a database. And then there's precision, which is, it gives a fraction of how many relevant documents there are from a specified number of documents that were retrieved. So this is a bit more focused in scope. It doesn't go over the entire database, it's just over the documents that were specifically obtained. So now that you got some background information on these concepts, TREC COVID is a collaboration that applies these concepts for medical journals. And it's a collaboration between the University of Texas, the National Institute of Standards and Technology, Oregon Health and Science University, and the U.S. National Library of Medicine, and the Allen Institute for AI. And it's meant to examine various information retrieval methods and how efficient they can be and how good they are at obtaining the most relevant and accurate articles. So peer-reviewed articles are the golden standard when it comes to searching for medical information. They're trusted by experts all across the field. Everybody uses them. And with so many articles and so many studies coming out every single day, the most important question is, how are health experts supposed to keep up with what journal articles are most relevant in an efficient manner? So how this task will improve information retrieval is to reduce the amount of time it takes to look for reliable data. It also aims to search for the most relevant reports by using comparison algorithms, and ultimately aims to prevent the spread of misinformation. You don't want a search engine to show you data from, last week when it could show you a report that came out an hour ago. You always want to make sure that the comparison is as up to date as possible. And what is being accounted for in this experiment? So the first one is how to choose the content to search through. What are you going to test your information retrieval algorithm on? And in this project, it was tested on a COVID-19 data set of research papers from the NIH. And then the second is, how do you develop a search engine in such a short matter of time? And to answer that is to build it upon an existing search engine. So in this case, it's through PySerini and Anserini, which are data retrieval toolkits available on GitHub. Anserini is a retrieval toolkit from the Lucene search engine library. It's open source, and it has a lot of resources with multi-stage ranking. And then PySerini is a more user-friendly interface to Anserini. It's very efficient to use with first-stage retrieval, and it includes queries and relevance judgments and indexes and evaluations. And other questions that are being accounted for in this experiment is, what are the appropriate information retrieval modalities for this experiment? How do you optimize a search engine for more specific situations? Because some people can just enter some keywords and they'll get results back, but other users will enter something much more specific. So how will it accommodate for that? And further, how can existing data be used to improve the search engine? So how can we potentially teach a search engine to improve upon itself each time? Other questions that are being accounted for is if event-specific training data can be created fast enough to have an impact. How can you quantitatively measure a search engine's efficiency? And when comparing different types of search algorithms, what characteristics are the most important to compare? And finally, how does one qualitatively evaluate the search engine? So the procedure for this project was that participants were given a corpus, which was the data set of all of the documents to evaluate. And they were also given a list of topics that they would enter in as queries to see what documents would come up every time they searched it up on their information retrieval system. And participants have 1 week to create their own information retrieval system and run 1,000 results per topic. And after that, results are gathered and manually evaluated, and judges rank how relevant each topic is. So in this experiment, so once everything was evaluated, or once the judges got to the evaluations, they went through each paper, and they had to sort if it was relevant, partially relevant, or not relevant. And this scale was used to determine how this algorithm, how accurate it was, and it also helped them compare them with one another. And here it shows for each topic how relevant each of the searches were, and here are the judgments that go with them. And for the technique that was used for this experiment was a pooling technique. So what they did was that, in order to save time, they got the top ranked results from each participant, and then judges manually ranked how, if it was the best document that the search engine could have gotten, or if it wasn't relevant, or if it just didn't have anything to do with the search query. So a difficulty that comes with this project is, it's just the massive reports that come in each day. It's really hard to maintain a current data set. And it's also, if you want to stay current, you have to download it over and over again. And you have to update it and add more articles and more new statistics each day. And the second was the lack of qualified judges to manually assess each article. These judges are experts in their field. These judges and also need to make the time to judge all of these different articles. So that's one difficulty that came with this. And in hopes of solving these difficulties, the first is just repeating the procedure and seeing if any other issues or if any other potential solutions come up. And it's with 5 topics each time, 5 new topics. And then there's also the possibility of including machine learning techniques in order to lessen the need of human judges, which would be by having the search engine build its own criteria and its own standards on its own. And finally, some personal takeaways that I got from this project was that I obtained a greater understanding on information retrieval methods, and I also got a greater insight on the statistical methods that overlap with bioinformatics, and I got experience with using GitHub and the repository and importing various toolkits from it. And overall, I just want to acknowledge everyone who was a part of this project, and I also want to acknowledge Dr. Hirsch. He provided he helped a lot with the background information of this project, and he also helped me understand a lot of these concepts a lot more better. They're very hard to grasp at first, but his explanations made them a lot more easy to digest. And I would also like to thank Dr. Chamberlain from OHSU. He was very helpful when it came to syntax errors and any coding errors that I encountered during this project. And I would also like to thank everybody at DMICE for listening to my presentation and for giving me this opportunity to, put my foot in the door when it came to machine learning. And I'd also like to thank the University at Buffalo, New York for expanding my knowledge and the Allen Institute for AI and Microsoft Research for the funding on this project. Thank you very much.
Great, thank you. Any questions from the audience? Okay. Since I was your mentor, I won't ask you questions here. Why don't we then move on to the third and final presentation. I see that Dr. Dorr is still here, but I think he wants his intern to introduce herself, so I can turn over the floor to Suzanne Navarro.
I am so sorry. I forgot to unmute. Give me a second, please. Okay. Good morning, everyone. My name is Suzanne Navarro, and I'm a rising senior at Jesuit High School in the lovely city of Portland, Oregon. And today I'll be presenting on the project I worked on this summer, the eCare Plan app for patients with multiple chronic conditions. Problem. Nearly 1 in 3 adults in America are currently affected by multiple chronic conditions, otherwise known as MCCs for short. MCCs disproportionately affect women, racial and ethnic minorities, and low-income individuals. As we know, patients with multiple conditions almost always see multiple providers to help with each of their conditions. A lack of care coordination amongst a patient's providers all too frequently results in wasted time and money. As shown in Figure 13, we see that people with 6+ chronic conditions, represented in purple, make up the smallest percentage of Medicare beneficiaries at 17%, and yet they account for the greatest percentage of Medicare spending at 53%. However, lack of care coordination, most importantly, results in fragmented, lower quality care and suboptimal health outcomes for patients, as evidenced by Figure 14. Figure 14 shows that those with 6+ chronic conditions are significantly more likely to be readmitted within 30 days of a hospital visit, making up 81% of these readmits. Potential solution in improving health information technology. In recent years, EHR, or electronic health record systems, have become widely implemented in all different types of healthcare settings. You may be familiar with Epic or MyChart, which are both EHR systems, Epic being a provider-facing system, while MyChart is a patient-facing system. And these EHR systems are a subset of Health IT having greatly improved care coordination among providers and the clarity and accessibility of medical data for non-MCC patients. However, there is little evidence that Health IT has improved patient care for MCC patients. The thought process behind this project is that if we improve Health IT, we may be able to maximize benefits for MCC patients. Project goal. The project goal is to improve the quality of care for MCC patients, especially those with chronic kidney disease, or CKD, by improving EHR systems. The proposed solution for reaching this goal was to build the eCare app, an app which will work in existing EHR workflows, will serve as a tool for both providers and patients that contains the patient's comprehensive care plan and all of their medical data in one place, will enhance patient understanding of their medical data, and will emphasize patient goals to providers. Collaborators. There were many collaborating institutions involved in this project. On the left, there's a screenshot of a slide from a deck of training slides that I will introduce later that summarizes the collaborators and their roles very well. The NIDDK, which is part of the NIH, funded app development, and Cognitive helped with the actual building of the app. ARC funded the testing and evaluation of the app, while RTI International and OHSU did the testing and evaluation. Throughout this summer, I attended many Zoom and WebEx meetings, almost all of them being meetings that recurred frequently, and got to experience and be a part of the coordination that has to happen between these collaborating institutions on tasks, deadlines, and such. However, there's one other resource that was instrumental in this project, and that resource is known as Fast Healthcare Interoperability Resources, or FHIR for short. And I might not be explaining this perfectly, but as one of my team members on this project, Matt, explained to me, code usually has to be rewritten for each EHR system that uses it, because EHR systems almost always interact with and store medical data in different ways. But FHIR solves this problem with its framework, as it standardizes data formats and interactions so that EHR code can be used on a variety of platforms without having to be rewritten. FHIR is part of what makes this project innovative, populating the eCare Plan app with data from Epic. The bottom right picture shows the FHIR workflow. Methods. First, both provider and patient-facing versions of the eCare Plan app were built. Here's a screenshot of what the health status evaluation and outcomes page of the app looks like in the provider-facing app to the left, and to the right is a screenshot of the corresponding page in the patient-facing app. Next, a lot of preparation for usability testing of the app was done. But before we get into that, however, I wanted to briefly introduce what this usability testing entails. It entails having facilitators such as myself and my team member Taylor observing providers walking through the app and getting their feedback on it. In preparation for this usability testing, a simulation patient dubbed Patricia Noel was designed to be the archetypal patient that would have this app as part of their care. She has MCC, advanced CKD, and multiple care teams across healthcare settings. The team, the eCare app team that is, created 3 different progressive medical scenarios for Patricia Noel in order to test all aspects of the app. To the right, you can see a screenshot of Patricia's scenarios, complete with medications, referrals, and more. In addition, because of her medical conditions and medical data, when she is used to test the app, the team will immediately know if the eCare Plan app isn't working the way it should. And since I use these terms quite often throughout the remainder of this presentation, I thought I'd mention that the term usability testing is essentially synonymous with user acceptance testing, or UAT. A UAT form was created to guide said testing, as it contains all of the questions that the facilitators of the usability testing ask participants in order to get their feedback. And I'll talk more about usability testing soon, but these questions were agreed upon by several of the project's collaborators and were crafted so as to make UAT as structured and efficient as possible. Here's a screenshot of a section of the current UAT form, which has gone through many revisions. Another thing that was done to prepare for usability testing was making a data collection form. I made one in Smartsheet, and it had to go through several revisions before we started scheduling UAT sessions. I used it to collect provider feedback during UAT, and it made collecting and interpreting feedback extremely efficient. Figuring out how to make this form so the data would be easiest to interpret and compare after collection took some thought. On this slide, you can see a screenshot of said Smartsheet form. One more thing that was done as preparation for UAT was the making of training materials for those learning to use the app. These materials include tip sheets, training sessions, and training slides, all meant to help those using the app feel more comfortable with it. On the top right, you can see a screenshot of part of a tip sheet made by Taylor, complete with guiding instructions and arrows. Towards the bottom is a training slide from the training slide deck made by RTI International to be used in training sessions that tells providers what to expect during UAT. UAT was conducted and involved scheduling hour-long blocks of time with providers and getting their feedback on matters such as functionality, usability, and how helpful the contents of the app would be for patient care. UAT helps us see how easy the app is to use for those who don't have as much experience with it, as well as how helpful the app is and would be for patients with MCC. And this usability testing was done in the app's test and live environments. The test environment for the provider-facing app can be accessed through Epic POC, and the test environment for the patient-facing app can be accessed through MyChart POC. Both environments are populated with Patricia Noel's medical data. The provider-facing app's live environment, conversely, is accessible through Epic Production and is populated with real patient data. The real patients whose data was chosen for usability testing had to meet the following inclusion criteria: that they were the participating provider's patient, so the provider could tell us if something wasn't showing on the app, and that they had MCCs, at least one of which is CKD, so as to test the app to the fullest extent. And before we move on to the next slide, I'd just like to quickly note that all team members that interacted with real patient data were trained to work with it so that there would be no breaches of privacy of any sort. Also, the top picture shows how the app can be accessed through Epic, whether that's Epic POC or Epic Production. And the bottom screenshot shows how the eCare Plan app would be accessed through MyChart POC. And over the next few slides, I've provided screenshots of the pages of the provider-facing app. And I'll pause for a few seconds before I continue on to the next slide, but here are the first 2 pages of the app. And here are the next 2, and I have these in order, by the way. And here is the last page. And hopefully seeing the pages of the app gives you a better sense of what we were asking of providers doing during your UAT. Findings. App strengths. Across the board, the app was found by participating providers to be intuitive to navigate and use. These providers thought the app would prove useful for more efficient and effective reviews of patient data and goals before visits, several of them citing the diagnoses, labs and vitals, including trends, and goals focus areas as most useful in this respect. Overall, these providers agree that the app will add substantial value to patient care. App limitations. However, there are a few problems within the app. There were some app downtimes during UAT, some of which were expected and others that were unexpected. So 2 of our providers that were part of our initial round of UAT needed to be partially rescheduled. Also, additional labs that we knew should have been showing were missing, and medications were slow to load for some of the more complicated patients. And by complicated, I mean that these patients had more data than the app was used to at that point in time. Goals were also usually missing from live patients. Furthermore, users requested to see comments from other providers and nurses in order to get additional detail not already recorded in the app about, for example, how good a patient had been with taking their medications. And here are 3 of the 5 app pages that I showed you before. And these are the 3 focus areas that I mentioned as being the provider's favorites. The providers specifically liked that pages 1 and 4, shown as the first and third screenshots on this slide, they like these pages because of their consolidation of key data while preserving necessary specificity, especially for the diagnoses part of the first screenshot and test results in the third screenshot here, in the tables and the charts. They also thought that the goals section under page 2 was really helpful and pretty innovative, as patient goals are not something that they are accustomed to seeing in other EHR systems like Epic. Resulting changes. Based on this first round of UAT, some changes were made. As I briefly mentioned before, we had been scheduling hour-long blocks of time for UAT, and at this point in time, they became 30-minute sessions for the sake of efficiency. In order to shorten the UAT accordingly, I helped with condensing and eliminating some questions in the UAT form and Smartsheet. With these changes made, we found that these 30-minute sessions worked wonderfully during our second round of UAT. Furthermore, OHSU and Cognitive fixed the app so that additional labs now show for live patients. I got to help with checking the app's logs in order to track down what errors were occurring within the app. During the process of getting this fixed, I did a fair amount of testing the app so I could ensure things had been fixed, especially for some of the more complicated patients. Testing the app involved being pretty well versed in Epic. For example, I would check to see if the labs in the patient's Epic chart matched with those showing in the app, and that they were showing all the results that they should have been. I did extensive testing with several different patients in order to test the app to the fullest extent, both with Patricia Noel in POC and with several real patients in production. With the real patients, I found some inconsistencies between the app and Epic, and compiled them into a spreadsheet and then made a Word doc with screenshots and notes on the problems, both of which helped with debugging the app. A lot of the problems that I found relating to data missing from the app have been due to problems with Fire working improperly, as Fire is still a relatively new tool. And here's a snippet of the Excel spreadsheet that I was talking about, except without the patient medical record numbers, or MRNs, showing, because those are easily identifiable. I would show you the aforementioned screenshots and notes document, but it has a lot of personal health information, and it would be hard to adequately redact. Future steps. Future steps for this project include continuing to conduct UAT with more providers from pre-selected clinics and having these providers train patients they selected on how to use the patient-facing app. These actions will complete the full rollout of the app to these pre-recruited clinics. Furthermore, creating a video walkthrough of the app to account for app downtimes has been deemed a necessary fallback for UAT. Both bullets 1 and 3 are currently in the works. Project takeaways. A lot goes into projects like these that involve so many people at various institutions. There's lots to keep on top of, and I never would have anticipated how many meetings I would be attending. But it's definitely necessary in order to keep everyone up to speed on what's happening in different areas of the project. Also, my team tracks conferences, grants, and manuscripts, something I didn't expect at all coming into this project. Because of this, I was able to participate in submitting an abstract about our project to the Academy Health Science of Dissemination and Implementation in Health Conference at Dr. Dor's suggestion. I am currently in the process of submitting to another conference as well. My last big takeaway is when you're working with so many people, and especially with something as volatile as technology, be prepared for things to go wrong and for things to come up or need improvements. Being flexible and having backup plans in place is key when working on projects like this one. And here are my citations. And as I conclude my presentation, I would like to give a very special thank you to Dr. Dor, my mentor, to Matt, MJ, and Taylor, a few of the members of the eCare Plan app team, the rest of the eCare and CMP teams, and to DMICE. They all made this internship such a great experience and have been so eager to help and have been so welcoming. And this concludes my presentation for today. Are there any questions?
Great, thank you. Any questions from the audience? Well, if not, actually, I will maybe ask you the same question I asked Ellie. Again, noting that the development of these standards like FHIR is something that many of us who've been working in this field for a long time see as such a positive development. Did you find any shortcomings. It sounds like you mentioned it on one of your slides when you were doing your usability evaluation, shortcomings in FHIR, the standard, and if so, what did you find?
I wasn't doing this firsthand, but I was getting a lot of input from the people that kind of were more involved than me. And what was happening was that FHIR wasn't collecting all of the information that it should have been and sending it to the app. And this would happen when there were FHIR downtimes. So it was unexpected, and especially with usability testing that we pre-schedule about a week and a half to 2 weeks in advance, we couldn't really like account for that, and we would just kind of be in the middle of usability testing, and we would have to say like, sorry, we do not know why this isn't showing. It was showing a day ago. So
Great. Any other questions, comments? Great. If not, well, so this pretty much brings our 2021 internship year to a close. The interns will still be around a little bit longer, finishing up their projects and getting ready to go back to school. It's great that at least we got to have the internship this year, because last year it was canceled at the beginning of the pandemic, and this year it had to be virtual. Maybe next year we'll be back to normal. But it sounds like all of the interns, both those who presented today and last week, had valuable experiences, and that is good to hear. To have those of you in college and high school experience our field of biomedical informatics. So thank you everyone for attending, and we'll see you at our next conference. Have a good day. Bye.
Bye.